performance, we have Dr. Sebastián Garcia Saizo from EIH and Dr. Dave Fitzgerald of HSS. This introduction, of course, is not for the people from PAHO, PAHO or from, but for the colleagues that are in some of the countries. Without further ado, we are going to ask, please, Dr. Garcia Saizo, that is going to have to leave a little bit quickly because he's in another activity, to please provide your welcome words so we can start the meeting. Go ahead, please. And thanks a lot, Bremen, and good morning, good afternoon, colleagues. It's a pleasure to be here and to be able to have this conversation about the topic that has been prioritized in the inner cooperation agendas, and that is also part of this focus that is established by the director Barbosa about the pillars about how we build a prioritized agenda in the recovery post-pandemic and how we learn from what we have built even before the pandemic. And I am talking specifically about this focus towards improving data and the information that we are generating in a topic of the highest relevance that we have in our region, that is maternal mortality, and this implies having more better data for decision making and building policies focused and on closing these gaps. As you know, in this prioritization, we need to think that we not only need the general data about what happens in a national context about maternal deaths, but also what happens in specific cases that helps us build the initiatives that are necessary to stop this problem. And that's what this search has to do about, this intended search, where we are looking not only to improve our national menu, but also enter into the data that help us know in a better way the causes for these maternal deaths. And in this way, uh, establish some solutions for this problem. As you know, this is one of the areas with the most impact in the years of the pandemic, where they are talking about a setback of at least 10 years in the values that we have of mortality, maternal mortality, and which implies a need of improving our data and decision making and the alternatives to reduce this and retake the progress that we had before the pandemic. This is part of an interprogram work that we've had for several years in Mexico. This initiative has at least 2 decades, and we have had great results. And what we are looking with this restating is that in this country, even those that have good statistics regarding maternal death, maternal mortality, can improve the data and the way they collect this data and the details about these actions. I select this work with the colleagues as part of the example that we can do at home in this work programmatic, and the importance of this punctual work that we are having by each of you that are in each of the countries, and that is the center of the instruction that we need today. How can we take this topic within the technical cooperation that we have with the countries? And of course, this also as a direct topic of cooperation amongst the countries. Well, I'm thankful with all of you. I'm eager to check all the support that we have required from EIH and my colleagues also from CLAP and EIH that we have worked in for so many years, and that takes us to this point. So thanks a lot and have a great day. Thanks a lot, Dr. Sebastián Garcia Saizo. And now we are going to ask the welcome words from the Director of Dave Fitzgerald, Director of the Department of Systems and Health Services. Go ahead, Dr. James. Thanks a lot, Bremen. It's a pleasure to see you, Susani as well, Director of Club, Sebastian. Thanks a lot also, Sebastian, and all the team from EIH for all the support for this important initiative. So, as Sebastian mentioned well, the key information for decision making is what we need. And in there, we are offering, we are facing a very specific context regarding the availability of information, concrete information based on the deep analysis of the context of the health systems and capability of these systems to answer about mortality. Mm, Many of the of much of the work that is done in the country is based on this and the estimations, because taking into account disaggregation of information is complex, difficult, all the necessary strategies, even at the level of the territory, institutional level, with human resources, health service, that we need to provide an adequate answer in the health system. Yeah, so this is an area of high importance for the answer of the integral organization to reduce maternal death in the region. So we are working, leaving now the pandemic with this new strategy to reduce the maternal death in the region. And this is a key strategy to strengthen the capabilities of the countries to identify the causes, reasons, the places, and the instructions that have a particular to improve the specific things in this context. And this is a joint work that we need to do not only at the PHO but also at the level of the countries, together with the experts and entities responsible for the information systems for health, together with the health services and the territories and the other countries. And it has to be a serious platform to face this huge challenge that we are facing, and we are going to improve this situation in each country. So congratulations everyone for this new initiative, Bremen, Susani, IAH, and together we are going to work to provide the necessary support for each country. Thanks a lot. Thanks a lot, Dr. Dave Fitzgerald. I'd like to tell you before we go to the main presentation that, as you will mention, Dr. Sebastian, Dr. James, that is an interprogram work from the beginning. The other part that is not visible because it is a very low profile kind of person, that is Dr. Antonio Sawesa, that is part leading this work since the IAH area, and is going to be participating in the next few minutes. But I would like to clarify that he's a key part of this process. And as you can see, this is an interprogram work, and for this we hired a specialist that is supporting the countries, and is something that is being financed by both departments, which makes it more inter-department, because it is easier when we say we work together. However, the resources are provided only by one side. In this case, actually, we are providing this from both departments. Without further ado, because we are a little bit behind, I'd like to ask Dr. Aline Jimenez to please take the floor so you can show everyone the methodology that many of you already know, but we have several countries that don't have it actually included. Go ahead, Aline, please. Thanks a lot, everyone. It is a great pleasure to be here together with you all, and I'd like to thank this space and thank everyone that took you time from your very busy agendas to be part of this session and to get to know and recognize this extremely important topic. I'm going to share my screen now. And well, first of all, I'd like to mention and insist in everything that has been mentioned about this topic of intended search for about maternal death. It has always been a priority for the organization. It's something that has been handled, and we have had cooperation in the different areas from 2015, and this is extremely important to insist. And the final objective of this search is to support the reduction of these maternal deaths. And we might think, how is it possible to get with a methodology that from the beginning looks for find these maternal deaths that were hidden behind bad registry, bad information, invisible to our eyes. How is it possible? Because it is an increase, momentaneous increase of the data. How can it end in a reduction at a medium period of this maternal reduction? And that is part of what I would like to answer in this presentation. Talking really about the burn, I will say it can be done in 5 minutes and it can be done in 5 hours. For me, it is a challenge to be able to transmit the importance and specifically the importance of this topic, aside from the component, how is this done without but it's very important to live in our conscious the importance of doing this. Precisely starting with this topic of importance, we'll know that maternal deaths, when they take place in a high percentage, you can see evidences of coverage, access, and quality of health services. And this is the key part of the why we study maternal deaths as we do. Why we have these committees for maternal deaths where we study each one of the cases to make sure which were the causes that led to death to a woman that didn't have a reason to die, because pregnancy is not a disease and we are not expecting the death of a pregnant woman. And that's why we say that most of these maternal deaths are avoidable. And that is why, and that is the fundament and the base of why we study them. Because most of the times when we study a maternal death, we can find problems in the health system, failures that through an action plan we can improve. And with this, we can avoid more maternal deaths. And not only maternal deaths, but also another death that happens due to the lack of supplies. And in here, I'm going to mention something very basic regarding when, for instance, there are no supplies to stop a hemorrhage, or where when we don't have an ambulance, when we see that, when we have a case of maternal death and we have a plan and implement it, I'm going to make sure that this ambulance is always going to be available from now on in this place. And this is not only going to avoid a maternal death, but all other deaths that could require this supply. And this is what can bring us the base of why we study this and why is it important that in each case of maternal death needs to be studied. Because if we leave one of these cases aside, then probably we are going to leave some problems without a solution. And this is going to lead us to have another maternal death for the same causes. So within that context is extremely important, and it might be something that have been said a lot. What is important to measure to improve? But in this specific case, it is not only about measuring just for the sake of it, but we need to make sure that we are having correct measurements, that we are studying all the maternal deaths and that took place to solve the situations that led to this maternal death and avoiding more, and in this way making sure that this maternal death reduces is really reduced. And well, precisely here I'd like to share this with you, and I'd like this to stay in your mind while we are in this talk, and is that each maternal death sub-registered is an opportunity that we lose to improve the health system. And in this context, well, at a world level, we recognize the problem that we have to have a good quality of information to avoid maternal deaths. On the one hand, because of sub-registry, but in the biggest amount of cases in most of the countries that have information that is considered by of quality is due to a bad classification. So in here, in this topic, we could have, or we could take actually 1 hour explaining which are these factors that can cause a sub-registry that is still present in some of the countries, even in our region. And same thing happens when we think about the factors that lead to having a bad classification. However, we don't have the time for this to enter into depth in each one of these. And it's important to mention that we have several factors here and of different characteristics and natures. The registry comes from cultural factors, especially in certain populations, and limitations that the state generates at some point is not intentionally generated, but that doesn't make it easy to provide a correct registry, like the distance from the medical units where we have physicians and the offices for a civil registry where they can provide the registry, the death certificate for the population. And that is the importance of providing some registry. But if we go to bad classification, we also have multifactor causes from the lack of knowledge when filling the information in the death certificate, where they don't forget to mention the state of pregnancy of a woman and is submitted in the certificate, up to mistakes that have to do with coding and selection of basic codes when they don't have training, proper training from the coders from the CI10. And why not to mention, obviously, there is also some cases of deliberate hiding that on one hand is can be caused due to what we say perverted incentives that sometimes the Ministry of Health places without this intention, of course, but providing some prices to a hospital that in a whole year didn't have a maternal death. And if this hospital at the end of the year has a maternal death, could be tempted to hide this, up to things that have to do with punishable reasons when there is a maternal death, for instance, against the team that was part of this medical attention. So it is a multi-factor reason, and the most of them in a certain percentage are present in our countries. And that's why, in a way or another, most countries have to work together in improving the quality of data regarding maternal death, trying to save all of these topics. And well, this is only going to be mentioned in a tangential way, but it's part of what has been done in order to try to solve this sub-registry that is in most of the countries, this interagency group that is generated by different international organizations that try to create an estimate that kind of solves this sub-registry and tries to measure as close as possible to reality the maternal death, and with the objective, of course, of monitoring and trying to make sure that the compliance of these um, sustainable development objectives. And this is a transitory solution, and I call it like that. Obviously, this is the term because well, basically, this is transitory because the real solution that is going to, let me go back, the real solution would be to make sure that none of these factors should be present. That would be the final solution. Every physician should be trained always regarding filling this death certificate. Each coder should also be aware of how to select the basic cause in the case of a maternal death, that there is no deliberate hiding, and that the population would have the possibility of registry and sensibilization. And here we have to work, and the organization is doing so in improving these aspects. However, this is going to take a long time working regarding the plan of basic statistics. And that's why I insist the transitory solution. And for several years, the first thing that we started doing were some periodical exercises of Ramos to estimate the subregistry of maternal death and evaluate progress. The problem with these exercises is that regularly they were periodical exercises that were done every 5 years even, that didn't allow really when we found a maternal death case that was hidden, didn't let us study it and do something to avoid the real causes that led this woman to death and improve the health system. On the other hand, what this did is towards what we are going to, as it was mentioned by Dr. Sebastian, almost for 20 years that we've started this search progress in Mexico, is to implement in general this Ramos methodology in a way that is executed continuously in the countries. So when we find maternal deaths hidden behind a bad registry, we can study them and we can even establish actions that allow us to work on this maternal death index. So this is going beyond the numbers. Obviously, when we think about intended search, is well, this is to have good numbers. Yeah, of course, we already mentioned about quality of information and to make sure that we are counting all maternal deaths, but this goes beyond that. And what we want is to make sure that all maternal deaths are studied. We identify a search plan and we execute it um, in order to avoid having more maternal deaths for those causes. And in that way, and that's why in that way in Mexico, in the general direction of information, the Mexican Center for Classification of Diseases 20 years ago started this intentional and intended search for causes of maternal death that has this objective of affecting this registry, correct the problems that might be there, and getting trusting information that can prevent and can generate a diminution of these maternal deaths. After several years of proved success of this intended search, where precisely one of the great achievements was that at some point this interagency group stopped creating estimates of the statistics, national statistics in Mexico. They recognized the numbers that the country was providing, and it's then that PAHO, that PAHO, started, of course, with support of the center. And I'd like to thank, of course, infinite thanks for this support regarding this implementation and option in the countries in the region, of course. They start spreading. And I said in 2015, this methodology. So, in general terms, and of course, we don't have all the time to get into details, but I'd like to mention that BERM has four different stages, four different processes. The first one, and this is extremely important because sometimes we think that the BERM is only the second component, identification and research of suspicious cases. But the BERM has a first component that is fundamental and is to make sure that all maternal deaths that have been confirmed, even those that were confirmed from the beginning, that in the death certificate is specified that it was a maternal death or that they entered in the immediate notification center to make sure that those deaths that were studied already are classified in the best way. And I can assure you that a high percentage of maternal deaths, when they are checked by the team of experts from the BERM, are reclassified. It means that probably it changes the fourth digit of the code generated as a basic cause. However, it provides an adjustment extremely specific of quality regarding classification. And many times, due to lack of knowledge, um, they can change and there can be some important changes in a classification of a maternal death that might have been notified and analyzed in the committees. And well, that is the first component. Obviously, the second component of research of suspicious cases, that is the core of the BERM, also has a component where they can make sure or are taking advantage of all external information so we can contribute to finding these maternal deaths and even some suspicious cases. And finally, and not less important, to make sure that each exercise is always having an annual investigation of results and the statistical analysis of it. I'm not going to get into detail in this part. However, I'd like to mention a few important parts in everything that has to do with reclassification of confirmed deaths. That is the first component of the BIRM. And it is extremely relevant not only the documentation, to have all documentation, for instance, that can be used in the committees of maternal death to make sure there is a good classification. However, also to make sure that the selection of the base cause can be done by experts in this area. The basic death of the death, sadly, in some cases, gets to be chosen in a clinical way in the committees when the committees, let's say, should provide a reclassification of this causal chain of death, and then make sure that an expert coder of CA10 selects the basic cause of death. And why is it important, and why do I mention this? Because this is what warranties that there is comparability amongst countries to continue, and I'm not going to explain this again, but to continue with this process so we can find the base cause of death as it is established by the WHO and the CI10, and make sure that this data is compatible amongst countries and, of course, also within the countries themselves. On the other hand, also regarding the identification of suspicious cases, I'd like to be precise and to mention that even though the most important part of this process is to search for suspicious cases, and according to a list of causes that have been previously identified in a percentage that is considerable, can be hiding a maternal death, for instance, hypovolemic shock, an acute abdomen, and a list of causes in women in fertile ages is not the only way to look for suspicious cases. And this is the only thing that I would like to leave for now clear in this section, the second component. I'm not going to mention in detail, but only number one that you see there uh, has to do with the search for suspicious cases based on the list that we call it the Ramos, the modified Ramos list. Really, the methodology that we have been shared is based on taking advantage of other information, other kinds of searches within the information we have, so we can find other suspicious cases. Not only with this list that I'm mentioning, that even though is the most important or the most important part of this identification of suspicious cases. Obviously, after the identification of suspicious cases, we have to recover certain evidences so we can distinguish, separate, and say that this case can be discarded as maternal death, or after having an oral autopsy, we can confirm that it was a maternal death. Once this identification is done, it is important to know that what follows is to make sure that this maternal death has a treatment that is similar to a maternal death that could be notified in the notification, immediate notification system. What does it mean? That this death is analyzed in the committee and that has to do with maternal deaths to identify causes, to have an action plan, and to make sure that one death regarding these causes takes place again. Regarding comparing with other sources, what is relevant here that I would like to highlight is that we must make use of all information that we have available regarding attention that was provided to a pregnant woman or in the last quarter, because it's going to help us generate cross information and confirm suspicious maternal deaths, or even detect suspicious additional suspicious cases. On the other hand, also important, and I always highlight this, to make sure that the BIRM exercise is done together with the official information provided by the country. And as the last component of the VERM is the creation of this uh, yearly report. Of course, it should be sent officially. So at some point, it can be taking into account in the estimation exercises provided by the interagency team. Now, just a few more slides that I wanted to check with you guys. Um, you can see here, and we could see this as the internal framework of maternal death, where we see a not immediate notification and this status and the committees, of course, the answer to avoid more deaths and future deaths, all of this, and the capturing of deaths in this is all the information provided in the search. That is also the filtered that makes sure that it's only one number of maternal deaths in the country that it can be made sure that is okay. And lastly, which are the necessary supplies to adopt the BERM? Even though you might not believe it, the most important part is not to have the capabilities to implement them. The most important part is to have a sensibilization, acceptance, and support from the authorities. And this is, as it was mentioned before, there's going to be a high in the numbers of maternal deaths. Why? Because we are going to start counting the real number of maternal deaths. But this is just something temporary, is part of the way towards the real reduction. And on the other hand, the coordination of the personnel in charge of this. What am I looking for here? We are looking for finding and other important parts. Make sure that the process is done with the correct normativity, this regarding all the people that have to be part of this methodology to make sure we have the availability of information within the Ministry of Health. There are three main areas that should be part of these systems of information in health: maternal health and epidemiology. At some point, we should involve also the Institute for Statistics for the real number, or the entity that has the possibility to make official these numbers, and of course to make sure that we have strengthened capabilities. And with this, I'd like to thank really that you heard me here, and I give back the microphone. I give back the floor. Thanks. Thanks a lot, Eline. And well, in truth, it is a lot of material altogether to be processed. And I would like to ask you to stop sharing your screen. Perfect. I'm going to share just one thing so we can open and have some space for questions and answers that I believe is the most important thing today, and also some comments. Together with Antonio and Aline, we've prepared a roadmap of how we think we could be working here. I apologize, I lost what I was going to share. You see my screen here, right? Not really. Okay, perfect. For those that answer through the chat, I'm going to share. Let's see. Okay, perfect. Really, we don't need these slides. Let me tell you directly. So what we've established is that we wanted today to show you what the verm was about. Obviously, with this, it is not enough. However, in the next steps, what we want to try to determine is to reach the interest expression that the ministries of health might have to implement the BERM, and the support that they might need from the main offices. And in this work, what we would thank you is in the cases when you are discussing the colleagues from the PHO with the colleagues in the countries that they have an interest on this, to send an email directly to Antonio Sangüesa or to me or one of us. But it would be first to have Antonio and me to see some interest. After we register the interest from the countries that talk with us, the first thing we are going to do is to organize some online meetings to start with the first steps. These first steps have to do mainly with creating a coordination team of VERM in the country, that it should not be 1,000 people, just the minimum amount is okay. And on the other hand, what we should do is to develop a work plan where it is important for the country to see it involving all the different areas that should be present and that Aline showed. And finally, uh, to finish this, when everything is working, to put this work on the field. So what does it mean? There are two things that we need to know. The paraben team is reduced, the BERM team is reduced, and if two countries wanted to work on BERM, we couldn't provide a direct answer right away. That's why we need to prioritize and to see the demand. And in second place, and I believe that this is central, is that we support with everything that has to do with technical cooperation from the headquarters of the PAHO. But whoever wants to do this work needs to warranty the financial support to provide the local meetings. So we needed to put everything together with Antonio. These final words about this. Antonio, would you like to provide a final remarks? Uh, it seems that he has his microphone on mute. You're on mute, Antonio. All right. Right. I was just saying that it was perfect, everything that you said. So we should proceed with the questions. Go ahead. So I give you, Antonio, the opportunity to receive the questions, and we are going to answer them together. We don't see any questions in the chat. We don't see hands risen. Good afternoon for some of you. Good morning from some others. My name is Susan Sehuja, the director of perinatology, and I have a question. And before we close, I'd like to first of all thank Aline for her excellent presentation. And I would like to say that, yeah, of course, we're going to send, there are several people asking where can they find the materials and references. And um, I believe that Bremen, Antonio, Aline is something we should answer. And now I see some hands up. So I'm going to shut up now. Thanks a lot, Susan, for your comment. We have 4 people registered, and we are going to answer what they were saying. So the first person, please take note, is Victoria Bertolino, then Raúl Medrano, then Karen Rangel, and finally Humberto Flores. So Victoria, go ahead, please. Thanks a lot, Bremen. I don't know why I cannot connect my camera. I don't know why I can't show my camera. Well, thanks a lot. First of all, congratulations. I'd like to say that it is a huge step towards the Burma. We had the experience in Argentina. First of all, we had it, of course, in the political will is the first. We did it in a province as a pilot, and then we advanced to reach all the country with a huge commitment. And I believe it's truth, of course, as Lynn mentioned. First, the numbers are going to rise, of course. However, then there is some commitment even from the country to provide and maintain policies that are more fit towards reduction. So I'd like to congratulate you, Bremen. Thanks a lot.
Ya el colega
Thanks. Now we have Raúl Medrano. He decided to say that his question was answered, so we are going to continue with Karen. Hello, good morning. How are you? My name, I'm Karen from Nayarit, Mexico. I'm a psychologist, and there was a time where we had the opportunity to be part of the BERM committee, and something that we detected there was that many of the women that passed away, that died after this period of 42 days, classified by BERM, had gestational losses. So around, and this is something that is not exact. Now that something that was mentioned before by Master Aline regarding the uh, publishing part, the published part, we calculate that 40% of the cases that we analyzed had some gestational losses. And these were women that looked for getting pregnant before a year, and the next pregnancy was done um, well, and finally they passed away. So now with this strategy that we have, we started this strategy as a preemption of detection of gestational losses and to cover that. So the intergenetic period is longer and to provide preemption, not only the maternal but also the perinatal part, trying to work with these women that were having this loss. They could accept maybe um, some prevention and widen this time. In Mexico, this normative says it has to be 2 years, and what we are trying to implement in Mexico is at least 1 year after this obstetric event and passing away of the baby, if this was gestational loss, so we can have this impact with the women, and it's something that we are training for. Thanks a lot, Karin. Something I'd like to do is to strengthen, I don't know how or where, to have real statistics and to have this support. Thanks a lot. Well, go ahead, Humberto. Humberto, you have your microphone on mute. Yep, yeah, you can hear me now, right? Okay, perfect. First of all, I'd like to thank for this invitation, this opportunity you gave us to be part of this training. I believe it's extremely important and vital because I really understand that the need of this strategy. My question is, developed countries really don't have a need for this strategy, for this activity. Thanks a lot for this very specific and concrete question. Well, Aline, I would give you the floor. Two main questions. This last one that Umberto mentioned, Antonio in this knows a lot more than I do, and he could answer. And the first one, where would they ask bibliography and references for the verm? So Aline and Antonio, go ahead, please, and answer. Well, thanks a lot. Regarding bibliography, you can find everything in the webpage of the General Direction of Information of the Mexican government. In the Mexican Center for Classification of Diseases, we have all the reports that we have published regarding burn. Also, the organization, the PHO PAHO, has the website of Relaxis, that is a compendium of the information that has to do with this methodology. And on the other hand, I was saying that the problem regarding the registry of maternal death is worldwide. Even the estimates and the interagency group does estimations to countries of the first world that they are not doing an active search process. There is always a possibility that there is a subregistry of a maternal death because there are factors that many times cannot be controlled. For instance, I was mentioning a new doctor, a new physician that for some reason didn't have a training of the correct filling of this death certificate and doesn't know how important it is to mention that women had preeclampsia 6 months before and died because of um, stroke, and we could have late maternal death. So that's why BIRM is important to be implemented in all countries. This is at least what I'd say. Thanks. Yeah, I'd like to confirm what Elena was saying, that there is a need that each country should implement the BIRM. Now I'm going to take advantage just to insist on something that Bremen mentioned at the beginning, that any of the countries that wants technical support from those of us that are supporting this initiative, please, we have sent as set as a maximum data deadline June. So for those that want this support, please send us a message. And it's important to insist that it's not only for implementation, but also to strengthen what the country is doing.
Es importante que
So I
nosotros nos
believe it's important that we can adapt to the needs that the countries might have, and this part is part of the work that we might do. Well, we have a few minutes, and I'm going to try to get some of the questions in the chat as my friend from CLAM sent me, Melina. And well, we'd like to mention everyone that asked questions. We are going to check this recording. If we can't answer them in this space, we're going to answer them later. One of the questions says, is there going to be a repercussion against the physicians that look for the cause of maternal death? Well, I'd say BERM is not the problem here. The physicians, we as physicians, doctors, physicians, um, nurses, uh, and professional midwives should be able to identify maternal deaths. What must not happen, what should not happen, and from the WHO and the WHO, we try to always have this concept of avoiding guilt, because what happens in our countries? In our countries, usually, they put all the guilt and responsibility of death that the nurse injected and provided a dosage that was not correct. A physician didn't do all the procedures he should or she should do. In reality, it's not an individual process. What we need to have clear when we are talking about the vigilance and answer to maternal death, no matter which technique is being used, be it Ramos, BIRM, or the authorities and national reports, what matters is that we should notify to try to avoid new deaths. If we sweep under the rug, the same things are going to keep happening. And we need to have clear that is common here that we look for for this situation. And the idea is to avoid this, because a maternal death is not responsibility of a specific individual, it's a responsibility of all the service where this was received, and in all the system and even beyond the system, because this person might come from the community where there are social factors, social determinants that can have an influence on this that is happening. We are going to the next question. Uh, what are the Ramos exercises? Ramos is a technique that is complex, that is based on looking for all the maternal death cases with women in fertile range of age. There is a huge work that and a lot of works that have been published. So the person that asked this question, this is not the moment to answer this question. So this person could look for more information online. This is something that is focused on looking for deaths of women that are infertile range of age. The participation and or community organization is important. What happens with the efficiencies to answer the demands of the users? Well, the committees of maternal death should have representatives from the civil society that shows the opinions and feelings of communities, and not any member of the civil society. The WHO says that to be part of these committees, this person that is part of this community should have enough training to really be able to have a proper opinion and not to be manipulated within the committees of maternal deaths. We have reached 3:55. I'm going to give the floor to my colleague, Antonio Sangüesa. So together with Dr. Susan Sehuja, Director of CLAM, can close our session of today. Thanks a lot for your time. I would just like to thank the participation of our colleagues and each one of our colleagues of the health ministries that are present here. Thanks a lot for your participation, and I'm going to give the floor now to Dr. Susan. Thanks a lot, Antonio, Aline, Bremen. Please allow me to start thanking those that are the strength of our regional team. Because many times we think to do the work of PAHO, we have a team that in the countries, when we need technical cooperation, that has the quality that is necessary. I'm really happy to see that we are reaching almost 500 attendees today, and it is important. And why should we talk about this? And by the way, I put the link of the webpage that Aline mentioned about the berm that is in the chat. Why is it important? Well, because we are capable, we manage to visualize better the maternal deaths and actually diminish them. And it's important not to lose focus that doing BIRM and doing all the methodologies, Ramos, whatever, as it was said by our famous colleague from Brazil, Escalente, he said, we in Brazil do this and we try to check. And there are many of the countries, as it was the case of Eleni, that have had an excellent experience in their countries, and these are the people leading this work. But we've had done this work with the objective of understanding epidemiological changes. I'm telling you, for instance, the most simple thing today. It is normal that many women survive 42 days and then they can pass away. That is a lot later. So if we don't understand, we can't tell where is the bottleneck where we cannot decide, we cannot improve the health. The main objective of this intended search to understand where we have the maternal deaths is this. We want the community to make sure that we are transparent, that we make sure that this belongs to the family, and we make sure that the work that we do and mortality. And as the directors have said in the beginning of the meeting, we can improve the estimates of the countries. One of the indexes that is the most important that you are going to find in any plan, be it of health, be it social, as the PHO, is maternal deaths. Maternal deaths is a topic of social equity, and we have to work towards this. That is the mission. And methodologies can change, but the commitment must be there. And that's why I'm so happy that until the end, we are with so many attendees. I'd like to ask the attendees just one more thing. This and all the seminars of PHO are available, are for free. Send to the other colleagues. Many colleagues are going to love to listen to Aline and all this presentation to get to know all the questions and understand more about this topic. To gather together as a team and check the presentations. This is an effort that is worth it because we deserve it. And we want to have a more committed America towards the rights of women and life of women. Thanks a lot, everyone, and have a great afternoon. I believe that is afternoon for everyone in the region, and we can meet as soon as possible in another meeting. Take care. Bye bye. Thanks a lot. Thanks a lot, everyone. Bye bye.